Welcome back. I'm wondering how many of you believe you may be able to relate to some of the information that's within this week's content. I bet to some degree we all can. We all may have ADHD moments. But keep in mind, in every classroom, there will be several students who are diagnosed with ADHD. As a future educator, it's vital to understand ADHD so you don't feel frustrated, upset, or defeated if you're working with a student that has ADHD. ADHD was first described by Dr. Heinrich Hoffmann in 1845. A physician who wrote books on medicine and psychiatry, Dr. Hoffmann was also a poet who became interested in writing for children when he couldn't find suitable materials to read to his 3-year-old son. The result was a book of poems, complete with illustrations, about children and their characteristics. The story of Fidgety Philip was an accurate description of a little boy who had attention deficit hyperactivity disorder. Yet, it wasn't until 1902 when the London physician George Still first identified ADHD. Still described a group of children who had average intelligence but exhibited impulsivity, behavioral problems, inattention, and hyperactivity resulting from a genetic dysfunction and not by poor child rearing. He characterized them as defective moral conduct. The 1930s marked the beginning of the childhood psychopharmacology when researchers found that certain medicines had a calming effect on individuals. Then, in the 1940s, Werner and Strauss coined the term Strauss syndrome to refer to children who had high levels of distractibility and hyperactivity. They also completed investigations that provided evidence that hyperactivity and impulsivity affected cognitive development. However, they only looked at children who had a brain injury. In the 1950s, Cruikshank and colleagues repeated and extended, with children with cerebral palsy, findings from Werner and Strauss, and found a link between attention and learning problems. In the 1950s and the 1960s, the term minimal brain injury was used to label those who were considered distractible and impulsive, not related to neurological disorders. This term was not used for long because there was not evidence that brain tissue was actually damaged. In the 1960s, gave way to the golden age of hyperactivity and a new label, hyperactive child syndrome. It wasn't until the late 1980s that the term ADHD was coined and focused on the inattention component. What we know about ADHD now is that it is considered to be a neurodevelopmental disorder affecting both children and adults. It is described as a persistent or ongoing pattern of inattention and/or hyperactivity and impulsivity that gets in the way of daily life or typical development. Individuals with ADHD may also have difficulties with maintaining attention, executive functioning, or the brain's ability to begin an activity, organize itself, and manage tasks, and working memory. ADHD is one of the most common behavioral conditions seen by pediatricians. Estimates of its prevalence in school-age children range from 4% to 12%, with rates of diagnosis increasing. Also, boys are more likely than girls to be diagnosed with a 2-to-1 ratio. Attention deficit hyperactivity disorder has 3 presentations, which vary by the symptoms someone experiences. These include inattentive, hyperactive impulsive, and combined inattentive and hyperactive impulsive. We can distinguish between the presentation from one another by looking at individuals' behavioral patterns associated with inattention, hyperactivity, and impulsivity. ADHD is based on observations of behaviors that children would exhibit in excess. Excess is the key. When compared to other same-age children, they would not exhibit these same behaviors at the same degree. ADHD inattentive type is at risk for being overlooked by educators and parents. These children are not generally disruptive and don't cause a lot of problems for teachers. They have very poor eye for detail, difficulty in maintaining attention, and are very disorganized, get distracted quite easily, and they can be impulsive. You may see any of these characteristics in excess: careless mistakes, an inability to focus, an inability to listen when spoken to, great difficulty in completing tasks, poor organization, deliberate efforts to avoid time-consuming tasks, loses lots of things, and easily distracted and very forgetful. Overall, they're not causing a whole lot of problems in the classroom except for problems to themselves and their learning. Children with hyperactive type typically stand out more. They may be observed fidgeting or squirming in their seats a bit. They have a great difficulty working quietly. These children may be described as driven by a motor. They're always on the go. In terms of impulsiveness, you see them blurt out answers before questions are asked in a classroom. They have a great deal of difficulty taking turns, and they interrupt or intrude on others. However, we need to keep in mind that they're not trying to be difficult or naughty. They're just naturally active, and they can test the patience of others quite easily. The combined type covers both the characteristics of the hyperactive and the inattentive type. A child could exhibit any combination of factors from impulsivity and hyperactivity and impulsivity to inattention. ADHD is classified as a neurodevelopmental disorder, so it has a neurological basis and affects development in many ways. There is a body of researchers who are interested in the anatomical differences and how they operate differently in someone who has ADHD. A neuron is a nerve cell located in the brain. Neurotransmitters are the chemicals that transport information between neurons. The brain has hundreds of different neurotransmitters, and they are responsible for everything from sleep, heart rate, to fear and anxiety, to mood and temperature. Some of the neurotransmitters that are often related to ADHD are dopamine and norepinephrine because they are responsible for attention and activity. If we imagine using a dipstick, like the dipstick used in oil or transmission fluid levels in our car, and apply that same principle to our brain, we would be able to check the neurotransmitter levels, finding which neurotransmitters are low, within normal range, or high. We also know that there are certain structures within the brain involved with ADHD. The prefrontal and frontal lobes are found to be associated with disorganization and inattention and are responsible for control of the executive functions or behaviors such as self-regulation, working memory, speech, and arousal levels. The cerebellum and basal ganglia are found to be associated with hyperactivity. What is important to remember is that the brain structure and chemistry in individuals with ADHD is different than those without ADHD. We're going to watch a quick video which explains exactly how the brain structure and chemistry are different while looking at individuals with ADHD.
Hello, I'm Dr. Gerald Chodak. Attention Deficit Hyperactivity Disorder, or ADHD, is a term many of us have probably heard before. But what does it actually mean? Simply put, ADHD is a common behavioral disorder that emerges in children before the age of 7. It can extend into adolescence and even adulthood. ADHD was first identified as a disorder in 1902, and for years doctors believed it was the result of serious brain damage. While that theory has since been proven wrong, the precise causes of ADHD are still unknown. What we do know is that the occurrence of ADHD is closely tied to biological factors such as the size and density of various brain structures and the way chemical reactions take place within the brain. For example, scientists have discovered that children with ADHD often have a smaller cortex, the part of the brain that controls thought and action. This diminished size usually occurs in the area of the cortex known as the frontal lobe. The frontal lobe is an especially important part of the brain, playing a role in many key functions, including impulse control, socialization, reason, and judgment. Experts believe this may help explain why some children with ADHD are more prone to drifting off, making sudden outbursts, or using poor judgment. Other research into ADHD has focused on nerve tissue in different areas of the brain. It appears that in children with ADHD, this nerve tissue is smaller or sometimes thinner than in normal children of the same age. While scientists aren't yet certain as to why, they believe these variations can affect a child's attention and impulse control. In addition to the physical differences in brain structure, many experts believe that people with ADHD, like those with depression, have chemical differences as well. Some studies have shown that children with ADHD have lower amounts of the neurotransmitter dopamine in the brain. Neurotransmitters are chemical messengers that carry information to and from nerve cells. Since dopamine plays a key role in the proper functioning of the cortex, not having enough of it could interfere with cognitive processes such as focusing and attention, the very same processes that people with ADHD struggle with. And though it's still being tested, the so-called dopamine theory seems to be supported by the fact that stimulants, which are often used to treat ADHD symptoms, work by increasing dopamine levels. Scientists still don't know the exact causes of ADHD, but much progress has been made. The more they discover about the roots of the disorder, the better equipped they'll be to develop more effective methods for understanding, diagnosing, and treating this common ailment.
There is also evidence that genetic factors play a large role in ADHD, and report about 1 to 3 people also have relatives who also have been diagnosed with ADHD. Environmental factors such as smoking and alcohol abuse, lead poisoning, low birth weight, and prematurity may contribute to ADHD. However, these factors may also lead to other issues and disabilities, including intellectual disabilities and learning disabilities. So how is ADHD diagnosed, and who can diagnose it? Because most children with ADHD are seen by a pediatrician, although some will see a child psychiatrist. The American Academy of Pediatrics, or the AAP, published a set of clinical practice guidelines for the diagnosis and management of ADHD. For the diagnosis of ADHD, the AAP guidelines emphasize the use of the criteria from the 5th edition of the DSM, the importance of obtaining information about the child's symptoms and behaviors in more than one environment, especially from the schools, and the search for coexisting conditions. Remember, all children are sometimes restless, sometimes act without thinking, sometimes daydream the time away. When the child's hyperactivity, distractibility, poor concentration, or impulsivity begin to affect performance at school, social relationships with other children, or behavior at home, ADHD may be suspected. But because the symptoms can vary so much across settings, ADHD may be difficult to diagnose. In children, the symptoms must be more frequent or severe than in children of the same age. In adults, the symptoms must be present since childhood and affects one's ability to function in daily life. Typically, the child's pediatrician will make the diagnosis, and then the school district will accept it. However, there are cases where the physician will make a diagnosis, and then the school is not convinced that the diagnosis is accurate and will initiate a second opinion. In these cases, schools don't have to make accommodations or efforts on behalf of the child if they don't accept the diagnosis, but they do have to get a qualified person who can provide a second opinion. The majority of the time, a school will not question a diagnosis from a physician. The school, the parent, and the physician are usually on the same page. Other individuals who can make a diagnosis include the school psychologist or the social worker. Keep in mind, though, when a school psychologist or a social worker are making the diagnosis, it is a school diagnosis given for the purpose of receiving services and program planning. It is not a medical diagnosis, so the scope will not reach beyond the school setting, and it does allow the student to receive services and supports in the classroom. It's important to know that all students with ADHD are not served under IDEA. In fact, many students are not even served within a 504 plan. There are children with ADHD in our schools, and the teachers don't even know that the child has been diagnosed with ADHD because the family has decided not to share the information. Some children with ADHD may have another disability that qualifies them underneath IDEA. For instance, a child could be identified as having a learning disability and also be diagnosed with ADHD. If ADHD is the only diagnosis and impacts a child's educational performance, then the student may qualify for an IEP and services underneath Other Health Impairment category, or OHI. About 2/3 of students who receive services for OHI do have an ADHD diagnosis. Many students with ADHD also are served within other disability categories because they have that comorbid disability. That means the student has ADHD plus another disability. When a physician suspects a child has ADHD, they will gather information from many sources to help identify if the characteristics are present with different people and across environments. Typically, they begin reviewing the child's medical history and will complete a physical exam. They also spend time interviewing the child and the parent and also review information gathered from ADHD screening instruments and behavior rating scales. The Conners rating scale is a screening tool that is often used to help identify students who may have ADHD. Do know that the Conners is just one assessment. There are many others that physicians or school staff may use when trying to identify if a child has ADHD. To recap, ADHD is typically diagnosed by a physician, through which parents and teachers provide documentation, share behavioral observation data, and complete screening tools or rating scales. One of the reasons so much information is collected is to be sure that ADHD is distinguished from other things going on, such as a conduct disorder or oppositional defiant disorder. This is often the biggest decision the physician needs to make. The key point to understand and remember is that children with ADHD are not intending or purposely trying to be difficult. There is a true neurological basis for their behaviors. Some children will not need any services or supports, but some may need a 504 plan or an IEP for support and to help them learn how to self-regulate behavior throughout their day. Let's see if you can answer these questions. Who usually diagnoses ADHD? Do most children with ADHD have IEPs? What disability category do children with ADHD receive services or qualify for an IEP under? How do and why should teachers collaborate with the child's physician and parents? If you had difficulties with any of these questions, it would be a good idea to go back and review your text and also re-watch the information that we've shared. Lastly, let's take a sneak peek at what ADHD may be like for some individuals. Read the following passage. Now, let's see if we can answer the questions. First, what was Tom trying but failing to fasten? Any ideas? The answer is C, his mind. Next question. How many students were in Tom's class? The answer is 25. Did anybody get that one right? Last but not least, what objects described in the passage has or have soft sides? Any thoughts? The answer is a nearby hill. How did you do? Did you even make it past the first two lines? In the upcoming module, we'll cover how ADHD may impact a student throughout their day.